When severe systemic infections take hold, physicians rely on foundational antibiotics to rapidly clear the pathogen. Rifampin is one of the most potent bactericidal agents available, capable of penetrating tissues and eradicating bacteria that other drugs cannot reach. Its efficacy was proven in the mid-20th century, and it remains a frontline agent in the treatment of tuberculosis. It also demonstrates an unmatched ability to reduce viable bacilli in patients suffering from Hansen's disease or leprosy, working faster than any other available agent. In modern hospitals, it is deployed against staphylococcal prosthetic valve endocarditis. Rifampin has a unique ability to penetrate bacterial biofilms, the thick protective matrices that bacteria build around themselves to block standard immune responses and antibiotics. Because of this sheer pharmacological potency, prescribers must rely on a strict mental framework to safely administer the drug without causing collateral damage. In clinical practice, this is known as the 4 Rs. The 4 Rs heuristic is the central navigational tool for prescribing rifampin safely. The first R stands for RNA polymerase inhibitor. Rifampin exerts its bactericidal effect by targeting and inhibiting bacterial DNA-dependent RNA polymerase, halting their ability to replicate. The second R stands for rapid bacterial resistance. Rifampin must never be used as a monotherapy. To prevent the rapid emergence of resistant strains, it requires strict combination protocols, like the RIPE regimen for tuberculosis or the RDC regimen for leprosy. The third R stands for red and orange body fluids. The drug causes an alarming but harmless discoloration of urine, sweat, and tears. Patients require clear counseling regarding stained clothing and the permanent discoloration of contact lenses. While the first 3 Rs govern infection control and patient counseling, the final R harbors a hidden mechanism shifting the patient's entire metabolic safety baseline. The fourth R reminds prescribers that rifampin revs up the P450 system. Rifampin is one of the most powerful known inducers of the hepatic cytochrome P450 network, a family of liver enzymes responsible for clearing a vast majority of medications from the human body. Inside the hepatocyte, the specific molecular trigger for this induction is the pregnane X receptor, PXR. The PXR is a specialized nuclear receptor designed to sense foreign toxins and upregulate the body's clearance enzymes in response. Rifampin molecules enter the liver cell, quickly bypass the fluid cytoplasm, and bind directly to the nuclear PXR. This PXR activation triggers a massive transcription event. The liver is suddenly flooded with newly synthesized enzymes, specifically the CYP3A4 and CYP2C9 isoenzymes. This artificial abundance of metabolic enzymes turns the liver into a hyper-efficient clearinghouse, dangerously accelerating the elimination of other life-saving medications the patient may be taking. The ultimate high-stakes victim of this enzymatic surge is warfarin, a common oral anticoagulant. Warfarin consists of 2 mirror image enantiomers. The highly potent S enantiomer relies on the CYP2C9 enzyme for clearance, while the R enantiomer relies on CYP3A4. Because rifampin massively induces both enzymes, the surplus CYP network rapidly dismantles and clears the warfarin from the bloodstream. This chart shows a patient's international normalized ratio, or INR. INR is a standardized measurement of how long it takes blood to clot. As the induced enzymes clear the warfarin, the patient's INR plummets drastically below the safe therapeutic threshold. This immediate loss of anticoagulation exposes the patient to severe, life-threatening thrombotic risks like stroke. To counter this, prescribers must progressively escalate the warfarin dose. Maintaining equilibrium often requires administering 2 to 5 times the patient's normal baseline dose. Surviving the initiation of concurrent therapy requires this aggressive, data-driven dose escalation, but this exact solution sets a deadly trap for the future. Eventually, the mycobacterial infection is cured, and the rifampin prescription is successfully discontinued. Here, the kinetics of enzyme modulation create a temporal mismatch. While enzyme inhibition happens in a matter of hours, enzyme induction requires actual protein synthesis. Reversing it creates a delayed offset. This reversal is called deinduction. Clearing excess enzymes rely entirely on their natural degradation half-life, a slow process taking 1 to 2 full weeks. As we can see on this continued chart, the rifampin is completely gone from the body, but the massive surplus of CYP enzymes remains active for days. During this lag, the massively escalated warfarin dose faces less metabolic resistance as the enzymes die off. Warfarin concentrations skyrocket. The clinical metric reflects this immediately. The INR spikes violently into supratherapeutic levels. Failing to preemptively taper the warfarin dose during this delayed de-induction phase leads directly to severe and sometimes fatal hemorrhagic events like macroscopic hematuria. To safely navigate this pharmacokinetic minefield, physicians rely on a strict clinical management protocol. The primary rule of initiation requires physicians to conduct a rigorous, active hunt for CYP 450 substrates in the patient's chart before writing a rifampin prescription. During concurrent therapy, there is a strict monitoring mandate. Guided INR testing is required 2 to 3 times weekly to safely scale the warfarin dose upward. Finally, the exit strategy requires a vigilant weekly down titration of warfarin for at least 2 weeks post-rifampin cessation to survive the de-induction lag. Effectively prescribing rifampin requires the physician to transition from simple infection control to a complex cycle of kinetic forecasting and dynamic dose management. This brings us back to the 4Rs heuristic, the ultimate safety checklist for the prescriber. It balances deploying immense bactericidal power against RNA polymerase with the strict use of combination therapy to block rapid resistance. It reminds prescribers to counsel patients on the highly visible yet harmless red and orange body fluents, and it warns of the invisible systemic danger, the profound induction of the P450 system that demands precise medication adjustments. Mastering rifampin requires recognizing that curing the infection is only half the battle. Successfully managing the metabolic fallout is what keeps the patient alive.